Yes. So my topic is what do we do if TSH doesn't normalize despite levothyroxine therapy? Just as a brush up of normal physiology, uh, let's remind ourselves that there exists a log linear relationship between FT4 and TSH, which is the primary reason why we use TSH as the screening investigation for any thyroid dysfunction. Obviously, there are caveats when we cannot do that, but uh, as a general rule, TSH is the diagnostic primary test to diagnose thyroid dysfunction, and we know that the definitions of subclinical hypo and hyperthyroidism include only alterations in TSH and not FT4, because TSH is very, very sensitive to minor alterations in FT3 and FT4. So on that note, so my topic is what do we do when TSH doesn't normalize with LT4 therapy? Here, actually, it is, this topic tells us that we are actually dealing with those individuals with primary hypothyroidism in whom we replace LT4 with adequate dose. And by adequate dose of LT4, I mean 1.6 to 1.8 microgram per kg of lean body weight. And despite this adequate dose replacement over a period of time, TSH does not normalize. So just to briefly mention, since I mentioned that TSH is the screening investigation for thyroid dysfunction, there are some caveats where measurement of TSH alone may be misleading. The important ones include a recent treatment of thyrotoxicosis. We know that TSH normalization takes time. Over a few months, it does normalize. And first to normalize in such cases with antithyroid drugs is T3 and T4. Then very importantly, central hypothyroidism, where despite having hypothyroidism, TSH may be low, normal, or even slightly elevated. Then very commonly non-thyroidal illness. I'm sure all of us who are practicing in multi-specialty hospitals may be getting a lot of consultations on thyroid function tests in COVID patients as well, where we see T3 and T4, particularly T3 goes down in the acute illness setting. So that is non-thyroidal illness. And sometimes TSH as interference and rare conditions of pituitary TSH adenoma and resistance to thyroid dysfunction. So on that note, let's go ahead with refractory hypothyroidism. By refractory, we mean that TSH does not normalize with adequate dosing of LT4 therapy. For the purpose of easy understanding and remembering, let's arbitrarily, bifurcate refractory hypothyroidism into pseudo refractoriness and true refractoriness. By pseudo, I mean that either the individual is not taking levothyroxine properly, or there is concomitant drug intake which hampers its absorption, or the very common occurrence of non-compliance to therapy, or when we inappropriately choose the normalization of normalization of TSH as the endpoint of treatment, when obviously the diagnosis is not primary hypothyroidism, and yes, assay artifacts which we many times tend to overlook. So these are clubbed into the subgroup of pseudo refractoriness. The true refractoriness occurs when there is any malabsorption syndrome, when there is inflammatory bowel disease, celiac disease, when somebody has had a gastric bypass or a biliopancreatic diversion, or atrophic gastritis, where there is no, gastric acid, which is actually important for absorption of LT4, or renal or liver dysfunction when there is alteration in serum proteins. So there occurs true refractoriness, and the others come under the heading of pseudo refractoriness. Now, just briefly touching each topic, what are the drugs that actually hinder LT4 absorption and hence lead to refractoriness or non-response to LT4 therapy? Well, anyone who is on preparations of iron, calcium, and oral antacids that contain magnesium or aluminium, then orlistat, sucralfate. Very importantly, very commonly prescribed drugs of proton pump inhibitors, then certain foodstuffs. So all these drugs and food items, particularly when we consume them along with LT4 dosage, then there can be, less absorption of LT4 and hence a pseudo refractoriness. Then yes, very importantly, we need to remember that the endpoint of levothyroxine replacement is TSH only in primary hypothyroidism. That's not true for central or secondary or tertiary hypothyroidism. For central hypothyroidism, as a rule of thumb, we may remember that we have to normalize total T4. If we know that what was the total T4 for a particular individual for a particular assay before he or she developed central hypothyroidism, then that is the target. And when that is not known, T4 normalization to within normal range, I mean at the midpoint of normal range of a particular assay, that is what we target. But we have to remember that we have to target normalization of free T4 when we suspect some serum protein alterations. And for that, we need to remember that thyroid hormones are heavily protein bound, both T4 and T3 beyond 99%. In fact, T4 is almost 100% protein bound. Very minute fraction is free. So we need to remember this. Why we need to remember this? Because there are certain drugs and there are certain pathological and physiological conditions where we have altered thyroxine binding globulin, and we cannot rely on total T4 for monitoring central hypothyroidism there. There, the monitoring has to be done by free T4 instead. So most important here to mention, pertinent to mention, is pregnancy or some lady who is on oral contraceptive pills which contain estrogen. Here we have hyperthyroxine binding globulinemia. So TBG is elevated and total T4 would be spuriously high. That is what is frequently seen when we get consultations for a first trimester or a second trimester lady, whereby TSH is normal and T4 is high, and the gynecologist is, not able to interpret the thyroid function profile. So yes, I'm going to spend some time on when do we suspect assay artifacts and what do we do about it. Well, very briefly, TSH assays, the first generation, which was there in the 1960s and 70s, they were radioimmunoassays, and they have been replaced now by, first they were replaced by the second generation isotopic IMAs. And currently we have, all of us are using, I'm sure all of us are using third generation non-isotopic immunometric assays. And they are third generation, which have a functional sensitivity of less than 0.01. So these are the assays. Usually we use eCLIA or CLIA. Chemiluminescence or electrochemiluminescence immunoassays, and those are the ones most commonly used these days, and they have a functional sensitivity of less than 0.01. The artifacts that sometimes lead to an inappropriately, usually a higher TSH, are grouped under these three headings here. They can be because of heterophile antibodies, antibodies to animal IgG. So that may be seen in somebody who has an exposure to animals, but sometimes they may be seen in somebody who has never seen a rat in his life too. So anti-animal antibodies are one of the reasons. Then it's quite important to remember that rheumatoid factor also sometimes interferes as an heterophile antibody and can lead to usually a falsely higher TSH. Then anti-TSH antibodies, when there is macro TSH, binds to IgG to form large complex akin to macroprolactin and hence lead to immunoreactive TSH, but not which is not bioactive. So there also there is false elevation of TSH, and very extremely rarely, it is said that in 1 in 30 million individuals, there is something called anti-ruthenium antibodies, and this is what is used in one of the assays, Alexis assay, where TSH may be spuriously high when we check individuals who have anti-ruthenium antibodies with that particular assay. So I'll just discuss briefly about them. What is anti-animal antibody and how do they interfere? Well, the kind of assays that we use are actually sandwich assays where there is a solid phase antibody and a soluble labeled antibody. The TSH is captured between these two antibodies, and the soluble labeled antibody is actually labeled by a substance that we pick up, and based on that we interpret the TSH concentration. When there is an interfering antibody that is able to link the two solid phase and soluble antibodies even without the presence of TSH, that is what we get. That is when we get a higher TSH than the actual concentration of TSH, and that is typically the case when we have anti-animal antibodies. So there is a false elevation, a spurious elevation of TSH, and how do we neutralize, or in other words, what do we do when we suspect? It's easy to repeat TSH in a different assay that may be using a heterophile antibody blocking tube or blocking reagents. Most of the modern assays use them. Another way of doing it, if we cannot repeat with a different assay, is to perform a serial dilution of the patient's serum. And upon serial dilution, we have to look for illusion of the TSH values. For example, if we dilute the serum from 1:1 to 1:2 to 1:5 and 1:10, upon dilution, there should be a fall in concentration of TSH. If that does not happen, that is when we think of heterophile antibodies as interference leading to spuriously high TSH values. So that is what we do when we avoid interference. We have a HAMA tube, a human anti-animal antibody tube, where there is a blocker of these antibodies. So TSH is once again the only thing that links the soluble and the solid phase antibody, and hence we get the right results. This is what is shown here. Upon elution or upon dilution, the TSH levels should come down proportionally to the dilution. If that does not happen, that is when we suspect heterophile antibodies. The other part of this assay interference is anti-TSH antibodies, where we get TSH, macro TSH. Now, here what happens is TSH binds to IgG to form large complex, which does not have any biologic activity, but it retains immunoactivity and hence is detected in the form of the TSH in the assays. Since this is, macro TSH, it is larger, it is not filtered at the glomeruli and causes falsely high TSH readings. It is akin to what we know as macroprolactin. When somebody we are suspecting as having, at not having hyperprolactinemia, but prolactin results show high prolactin levels. And this is one such data, one of the studies that shows that as many as 1.6% of individuals in this particular study who had subclinical hypothyroidism actually had macro TSH. So that is a rough idea of the kind of prevalence that may get in our clinic setting as well. So what do we do in a nutshell when we suspect a clinically inconsistent serum TSH result? And what we do, it's easy to repeat TSH in another assay. If the result is discrepant, meaning thereby when the TSH is normalized in another assay and abnormal only in one particular assay, that is when we strongly suspect assay interference. Alternatively, we perform a serial dilution. If there is a non-linear recovery, which means that TSH does not reduce upon serial dilution as well, then that is when we suspect a assay interference. And when we do suspect an assay interference, we can either do HAMA tube studies where there is a blocking agent of anti-animal antibodies as well. So when after doing that, we get appropriate TSH level, so likely heterophile antibodies is the diagnosis. We also measure rheumatoid factor. Rheumatoid factor also interferes with some assays. And if RF is positive, that may be the probable diagnosis, and we have to do TSH with a different assay there as well. If both of them come out to be negative, then we consider macro TSH, and some laboratories offer the PEG precipitation test like we do for macroprolactin, so that can help us out. So this part we dealt with about assay interference. What we usually get here is sometimes TSH can be suppressed as well, but the usual case scenario is that when we have heterophile antibodies or macro TSH, the T4 and T3, particularly T4 lies within range, and we get elevation of TSH only. So we may be, spuriously or wrongly led towards increasing LT4 dose of the individual, but we have to have a clinical judgment there. Non-compliance, actually, I should have spoken earlier, but I'm speaking it towards the end of my presentation because other things have to be ruled out, including an assay artifact, before we embark upon a LT4 absorption test, which I'll be dealing with in this part of the presentation. So non-compliance, obviously, we have to think as one of the first probable diagnosis or interference when we are not able to normalize LT4, because many patients do not want to take LT4 for long periods of time. They skip doses, they don't take it empty stomach, they take it with other drugs that cause hindrance of LT4 absorption. So first and foremost, we have to take the patient into confidence, and we have to have a good 10-minute talk, and we have to ask the patient whether or not he or she is consuming it. We have to take the attendants into confidence. We may get some clues from there. Sometimes it helps to, particularly if the individual is a teenager or a kid, sometimes it helps to tell the parents to give LT4 supervised in front of them. If all that is taken care of and still we do not get the answers, we have to rule out malabsorption syndromes. Finally, we can think of LT4 absorption test as well. So when do we think of malabsorption syndromes? Obviously, careful history and examination. Then routine CBC and chemistry can help us with certain clues that tell us that there may be a malabsorption, which is the reason why TSH is not normalized. We can always do an IgA, anti-TTG, and total serum IgA to check for as the screening test for celiac disease. And if there is a suspicion, we have to refer to our GI counterparts so that they can, further evaluate and establish a diagnosis. So just with these routine tests, we can, get some clues. So in CBC, what we are looking for the individual, particularly somebody who has a celiac disease, has hypoalbuminemia, and on CBC, he or she may have a microhypopicture of anemia. There may be MHC, MCHC may be low, hemoglobin may be low, and iron profile may also tell us that TIBC is high and serum iron is less. Albumin, there may be hypoalbuminemia. There may be ALP may be high, bone-specific alkaline phosphatase, or when there is liver disease, then liver alkaline phosphatase may be high. When there is hypocalcemia, once again, we can think of either a liver disease or a malabsorption once again. Serum phosphate, again, hypophosphatemia may indicate a malabsorption, or hyper may indicate a hyperparathyroidism. Then renal disease can be indicated by renal function test. So we can derive subtle clues that help us guide further evaluation. Very important to mention a simple test of IgA anti-TTG. It is slightly costly, but it helps a lot when we have a clinical suspicion of celiac disease. So we have to identify the zebra among the horses, because we get whole lots of patients, all of us do, I'm sure, who have TSH, which is not being normalized. So we have to identify zebra among the horses and use our tests judiciously. Now, finally, I come back to, I move forward to LT4 absorption test. It can be done. It is a bit cumbersome, but can be done when we do not find the answers. I beg your pardon for this busy slide. I'll just take a couple of minutes here. How do we do it? I have done it during my DM time on 3 occasions. And let me tell you, on all 3 of them, the interpretation was non-compliance. So that's all the answer we got from doing this test. So for someone whom TSH is not being normalized, despite being on adequate replacement dose of levothyroxine, first and foremost, a proper history of GI dysfunction, proper history of drug intake, whether it is being taken empty stomach, whether other drugs that can interfere with them are not being taken. We have to keep in mind whether there is assay interference, and like we talked, we have to rule that out. We have to think of no contraindications to high dose LT4 therapy, because that is what we are going to give while performing this test. So pre-test, we have to exclude these few things. And once we satisfy that we do not have the answer to why TSH is not being normalized, only then we go ahead and perform this LT4 absorption test. The patient has to be fasted from midnight. And yes, under direct supervision, we give 7-day quota of levothyroxine dose. Yes, it is 7-day quota. We calculated based upon the formula of 1.6 into body weight, and we multiply, that is per day dosage, we multiply that by 7, and we give that in one go, in empty stomach, in fasting manner to the individual. And yes, we give a full glass of water after that orally, and we keep the individual under observation. We take periodic blood samples for both FT4 and TSH at 30, 45, 60, 90 minutes. Obviously, we can prolong it if we wish to, 120, 240, and 360 minutes. And some, regimens tell us that we should continue this test for a period of 4 or 5 weeks, and some say that we need not. But this particular reference tells us that we need to continue this weekly supervised dose. We need to continue for a further 5 weeks. So that will be a total of 6 weeks. And on each visit, we take blood samples for FT4, FT3, and TSH. So that is how we perform it. Pre-test, we exclude other things. We look for contraindication. Any cardiac issue should not be there before giving 7-day quota. We calculate the dose based upon body weight, multiply by 7, and give 7-day quota at one go. And we periodically take blood samples. This is what we expect. We have a formula. I'll just go through it. We calculate volume of distribution as 0.442 into the body mass index. And we calculate the percentage absorption of LT4 by multiplying the increment in LT4. For example, if we take at the 0-hour LT4 and we take a 60-minute LT4 value by blood test, we calculate the difference and we take that as an increment. We multiply by that by 10 and by the volume of distribution divided by the total administered LT4 dose. We get it as a percentage, and the normal absorption is 60 to 100%. And how do we interpret this? Well, if on following up the patient for 5 or 6 weeks, in which we are giving a weekly supervised a week quota of like levothyroxine over a period of 4 or 5 weeks or 6 weeks, if TSH normalizes, then the diagnosis is probably non-compliance. The individual was not taking it. If there is inadequate FT4 rise post-thyroxine administration, then we have to think of a GI condition where there is malabsorption. If there is consistent rise in FT4 post-thyroxine but no change in TSH, then we are thinking of some rare diagnosis of thyroxine, of TH, thyroid hormone metabolism. So we'll not go into the details of that. As I said, I have done this test thrice in my DM time, and all 3 occasions the diagnosis was actually non-compliance. So most often we come back to this category of diagnosis only, non-compliance. It happens most of the times. And yes, celiac disease is also pretty common. When we keep screening individuals for this disease, yes, it does turn up many times. And when, as Dr. Mohan talked about, when we have an individual who has profound hypothyroidism, the TTG is also positive, we should always keep in mind that there may be a concomitant adrenal insufficiency as well when the diagnosis becomes APS type 2. So that just, I mean, off my topic a bit, but we need to remember all that. So that was about pseudo refractoriness. So true refractoriness, what do we do when there is true refractoriness actually? Well, there is no clear-cut answer. When there is a malabsorption, we get that treated from our GI counterparts. As malabsorption improves, LT4, absorption may improve. And for the time being, we have to periodically step up LT4 dose to whatever amount that helps us normalize TSH value, because whatever LT4 we give, it is probably not being absorbed. So we have to give a higher dose. And yes, we have to monitor and maintain TSH in the target range. That is how we can help these individuals. So to summarize my presentation, we must know the normal thyroid physiology and thyroid hormone protein binding to be able to interpret thyroid hormone tests accurately. We have to, I mean, as a first step, we have to rule out drug interference and improper intake of LT4, non-compliance, because these are the first and foremost diagnoses that sometimes happen. The individual may be consuming LT4 immediately before breakfast, and that is the foremost reason most of the times that LT4 is not leading to a reduction in TSH concentrations. If that is not there, then we have to suspect TSH assay interference, and easiest way to do that is to check from a different assay from a different laboratory. Comes out to be normal, we know what we are dealing with. Or we can perform a serial dilution as well. And if all above ruled out and we still do not have the answer and we want to get the answer, then we have to consider LT4 absorption test. That sometimes helps, but usually the diagnosis comes out to be non-compliance once again. So that's all from my side.